Good morning, everyone. I think after the wonderful gala dinner last night, probably most of the participants enjoy very much. So that makes this limited participation of this early morning breakout section. But because we have a very tight schedule today in this room, so I suppose we have to move on. And would you just allow me to introduce the first speaker, Dr. Trevor Fell. He is going to present to us repairing extensive valve prolapse with minimal invasive valve surgery. So let's welcome Trevor.
Thank you very much, Mr. Chair. Morning. Yeah, there's a lot of us. Anyway, my topic is something that I really enjoy a lot. Of course, as we know, when we do mitral surgery, you're going to get confronted with a lot of different pathologies, and the whole idea is to assess the valve adequately preoperatively and intraoperatively, and then work out how to do your repair. MIVS has come a long way, and over time you progress to really going to smaller and smaller incisions, which is really beneficial to patients. The one thing I think has been a big advantage is watching cardiologists do TAVI, and I watched them use ProGlide, and I thought, if a cardiologist can do a percutaneous stitch, I can. So I taught myself how to use ProGlide. So we now put all our patients on pump through the groin using ProGlide with small incisions. The second, or the slide in the middle, you can see we've got a sheath in the left-sided femoral, and that was for the intraclude. So you can really do these procedures now, and the last slide on the right shows after decannulation, you can hardly see the incisions, and obviously lymphocyte is something of the past. So it's something I'd encourage you to do, because ProGlide usage is really quite simple. Now, the principles stay the same for mitral valve repair, and as many of us have sort of postulated over the years, choose a technique, know how to use the technique well, and then take that on into your minimally invasive forum. However, I do think it's important that all ways of repairing valves should be well understood if you want to do adequate mitral surgery. And the reason we adopted the loop technique was that there was a lot of techniques described that if you look at these, and I'll just flick through these slides, where we have a muscle shortening with a split and then tuck technique. I mean, trying to do that minimally invasively would be a nightmare. And similarly with muscle shortening procedure. And then lastly, again, this technique. So I just pulled these to show that trying to do this through small incision and getting subvalvular would be really quite difficult. And we felt that adopting the respect technique and not to resect would be what we would do. And we knew that Gore-Tex had a really good history in the literature for durability. And they're just 3 papers that I pulled to show that they really give excellent long-term results. And we decided that the loop would be the way to go. We visited Germany, and if anybody got to know Frau Conrad, who was Fred's scrub nurse, she was not the most talkative lady, but if you got on the right side, she would teach you how to do these loops. As I said the other day, in Germany, they would make their own loops and then sterilize them. And that's against the law in Australia. You can't do that. So you have to make your loops on table, which always used to waste a bit of time. But now, fortunately, we have commercially available loops preformed at certain lengths, which makes implantation very easy. When we got back to Australia, you'll see at the bottom an instrument. We tried to purchase the rulers to take them back, but they would quote us the European prices. We were just astronomical. And in the early 2000s, we still had instrument makers in the hospital, and they would make instruments for us. So the instrument maker made me this little ruler, which we used initially. And then my colleague, Robert Tam, found another interesting way to make loops, which is a lot quicker than doing it sort of the button repair technique on Teflon. And he published that in the journals. So you're all very familiar with the loop technique. The thing about it is to work out where you're going to land your pledget with loops according to where your prolapse is. And there's some diagrams here that show that if you have anterior leaflet, you can put cords on the whole leaflet quite easily. And similarly, if you've got commissural prolapse, you can put a set of cords on that without any problems. and again, the other commissure, pretty simple to just put the loops on and do it. And this is Fred in the early series that he started. And in general, anterior leaflet cords were longer and the posterior cords were shorter. We would very seldom use 10 millimeter loops. Often, it'll be between 18 and 20, the lengths we put in the posterior leaflet. We like to see pliability in the leaflet, that it's mobile after the repair and not stiff and pulled down. There are nowadays available little Bouchard retractors which you can put into the annulus, and that opens up the subvalve apparatus very beautifully for you to place your loops. And this is just another example of the loops we constructed ourselves and placed in position. And I showed this the other day. This is a diagram of what we did when we did really extensive Barlow type valves. We made this operation extremely difficult because there were a lot of things we didn't understand at that time about mitral valve repair, particularly in the bileaflet and Barlow type valves. So we would put 3 sets of loops onto the papillary muscles. The loops onto P2, you'll see that the one loop actually crosses the midline, and that's not a good idea. It was difficult to really do the schematic presentation to demonstrate that, but the one thing about the loop technique is never cross the midline. So that tends to distract the leaflet downwards, and you won't get a good capitation zone, and without any doubt, you'll have leakage and not an adequate repair. But the one thing, and the gentleman that helped me, this was Satsuki Fukushima from Japan, and we reviewed not many patients. We only had 25 at that stage. But the one thing we did find was that we really did get really good adequate lengths of coaptation, which is one of the really important things to try and achieve for good long-term outcomes. So you can see all the repairs at coaptation zones of over 10 and some even over 20 millimeters. And that's one of the reasons we adopted and stuck to the respect and not resect technique. So we would almost never resect tissue, always just use all the tissue we have in the valve. And for P2 prolapse, Fred and his colleagues showed there was absolutely no difference between using a loop and resection techniques. And so on that basis, we all realized that we can get the same results using the loops. I think probably the most important thing, and this is an old slide, I apologize, but Fred's retired and I'm not sure where the data is out in Leipzig, but I think the most important thing about the loop technique was that we could actually get the same results with anterior leaflet and bileaflet prolapse, which is one of the Achilles heels of valve repairs, particularly anterior leaflet prolapse, to fix that. The surgeons struggled with the concept and didn't always get good results. And of course, then along came the concept of functional prolapse, and there are a lot of names for this. The one I like most is what my friend and colleague from Melbourne, Aubrey, and he's an anesthetist, they called it late systolic splaying. And in the animation here, which I showed the other day, you can clearly see this. And if you see this on echo, and transesophageal echo, pre and intra-op, you've already won a battle with a very complex valve, because about 20% of these patients simply require a ring, and that's it, the operation's done. And we have follow-up now to 5 years, just putting a ring on patients with 0 MR. So I think the key to this, however, is also going to be the intraoperative assessment. And that's why we keep harping on and saying that doing successful valve repair is a strategy that starts looking at the preoperative TOE. And I can't emphasize enough, to this day, we do not have a patient in theater that hasn't had a pre-op toe. Intraoperative toe is not where you start working out what to do with the valve. So we'd see the pre-op toes and have a plan in place, and we would just confirm that intraoperatively and then do the repair and then see the post-pump repair. And I think what you have to take into account is the whole complex of the valve, which we'll finish off with a little later on. I did show this the other day. Hang on, sorry, I don't know what I did wrong. I don't know where my cursor's gone. I've lost my cursor. Oh, there it is. Have you got the cursor there, have you? Can you just play that? I wish I could, because I can speed it up. Anyway, it's not that important. This was just an extensive Barlow type valve, and basically we put a ring on this patient. It's really a pity I can't play it. Okay, doesn't matter. And again, this is a lady we did with extensive prolapse. And the key again is that late systolic splaying or disjunction, where you can see the valve splaying out. And if you put color on, which I haven't got in these slides, or echoes, the regurgitant jet is always latent systole, and it's almost always central. It's not directed anteriorly or posteriorly. And this is just the same patient at a different level of toe. And again, unfortunately, I can't play this, but we'll talk about that at the end. But this lady with that extensive prolapse ended up just with a ring, and you can see we have a large surface area of coaptation, and there was no mitral regurgitation. So we learned that, complex valves we used to put a whole lot of cords on and spend a lot of time doing it was completely unnecessary because, as I said, we follow-ups now at 5 years with no recurrent mitral regurgitation. And that's just the same patient again. So in summary, wrapping up, I don't think we can emphasize enough that choose a technique that works for you. Look at the valve as a whole. If you have a short anterior leaflet, then you really have to start thinking very carefully, are you going to get a successful repair? And think about downsizing your ring. Correlate all aspects of the valve with your intraoperative toe findings. Assess the leaflets very carefully. And those patients with the late systolic splaying, if the leaflets all come up to a reference point and they don't protrude or prolapse beyond that, then you simply need to put a ring in. A lot of those patients, however, will require cords, usually just to P2, and you'll find that the P2 part of the valve would be prolapsing. And if you put cords on that and pull it down, and you can be quite aggressive in pulling those cords, the leaflet down, you often require short loops or cords because you have a lot of tissue to coapt against the posterior leaflet. I think it's important to close. I use the wrong term, clefts. I think the better description is indentations. If you have indentations between the leaflets, sometimes you can get small leaks through that. I think these patients with the large prolapsing leaflets often require a big ring because there's a lot of leaflet tissue. But the whole strategy should be around very careful assessment, work out what repair is going to work best for you, and it doesn't matter how much prolapse there is, you can certainly fix over 99, in our hands, probably 96, 97% of mitral valves minimally invasively with the loop technique that we use. I thank you for your time.
Thank you, Trevor. Is there any question from the floor? Or question from Dr. Okada?
Yeah, and your technique only for caudal adjustment using a loop technique without resection. So I have sometimes resection suture technique for transverse redundancy of the posterior leaflet. So you don't have such a case?
Sorry, I didn't quite. What about the posterior leaflet, sorry?
So-called, not prolapse, but the transverse redundancy sometimes I met. So and in those cases, I resect the triangular resection to adjust the surface to make a smooth surface.
No, we haven't employed that, but I don't think that's unreasonable. As I said, I think you just have to plan your strategy very carefully. I think the most important thing is you have to look at all segments of the valve. I think the biggest mistake I see people make is they look at the toe and they go, oh, this is just a P2, and off they go. They don't think about the size of the P2, how long it is, the anterior leaflet, are there clefts, how small is P1 and P3. And if they do resections, before you know it, they've cut out way too much tissue, and then they find themselves in trouble. But as I said, I haven't employed that, but I think it's a very good technique for a nice, smooth surface area.
Yeah, question from the floor. Dr. Songchai.
Very nice presentation. I have one question. For loop technique, do you have any problem about the SAM?
Well, yeah, we do. Again, that's why I kind of stressed your preoperative toe. For these big Barlow valves, never. It's amazing. You know, you think all that tissue can have a problem. SAM, I think two things happen. You probably undersized the ring, and if you go back, you'll find you need a bigger ring in a lot of circumstances, or he didn't pull the leaflet down enough. And that's why I try to emphasize looking at the height and the size of both leaflets. If you've got a big anterior leaflet and a lot of posterior leaflet, then you've got to shorten your cords a lot and try and use a bigger ring as possible. And so I think a lot of it can be avoided by careful planning, but trust me, we all make that mistake. You know, you sort of just go through the case and don't think it through very carefully. But with the big complex cases like that Barlow I showed you, we've never seen who had a problem with Sam. It's quite amazing. But I think it's such a big annulus, they take a big ring anyway, and I think that's what helps with that.
Yeah, I think my experience to Dr. Songchai's question, actually Sam could happen in any strategy. But our concern would be try to reduce the height of PML. So no matter is resection or respect strategy. My experience, actually, I will do same as Dr. Treble, Dr. Fell. I try to respect as much as possible. I rarely resect the tissue, but I will try to bring down the PML to the ventricle. So try to have the coaptation line in the posterior part, like a 2 to 1 of the coaptation line. So I try, I think most of the surgeon, the mitral valve repair surgeon, will try to prevent this kind of a condition of SAM during the operation of the design, during the design strategy. Yeah. Also, for the question from Okada Sensei, I would say for those transverse redundancy, usually I will have artificial coda in between to bring down those transverse redundancy causing prolapse. So we will have a anchoring coda to pull down in the middle. So we still could have a pretty good coaptation. Yeah. So let's move to the second topic.
I would just respectfully ask to be excused from this forum. I have to go next door, but I'll be back. So it's very rude that a speaker leaves the forum, but if you could excuse me for 15 minutes and I'll be back. Thank you.
Thank you. Thank you. Oh, so let's move to the second topic. The second topic will be given by Dr. Okada. According to the schedule, this is Takanashi Sensei. Takanashi Sensei missed the opportunity to show in this Congress. So he asked his good friend, Okada Sensei, to reprise his talk and also as my co-chair. So Okada Sensei is going to present to us mitral valve repair for infective endocarditis. He's the famous surgeon in Japan.
Good morning.
Valve Center. Yeah.
My topic is mitral valve repair for infective endocarditis. So then, mitral infective endocarditis. We met a variety of pathology and variety of infection site was seen. The almost until 1990, just replaced the infected mitral valve. But at 1990, Gerald Griffiths from Carpentier Group reported valve repair in acute endocarditis. And then the Cleveland Clinic, Toby Cosgrove group, repair mitral valve repair for bacterial endocarditis, including active and healed. So at that time, I started mitral valve repair for infective endocarditis, 1988, and then until December 2011, I had, fortunately, 157 cases. Among that, 99% patient number of patient 14 patient which suffer from very complicated and multi-lesion infection unfortunately replaced by prosthesis. But fortunately, 91%, patient number 143 patient repaired successfully. And the patient characteristics of mitral valve repair for infective endocarditis, you can see a very young mean age. Mean age was 49, very, very young. And active 36%, and mean age 51, healed case 47. And male was predominant, 65%. And as you know, the cardiac rhythm, most of the patient cardiac rhythm was sinus. And by surgical analysis of the site of valve lesion, infection site, the active 41 patient healed 92% patient. Each group, 60% of the patient suffered by leaflet lesion, not single. So reparative procedures for infected mitral valve is, at first, complete resection and infected lesion and thick restricted post-inflammatory tissue. This is the first step without considering how to repair. Just cut, resect the abnormal infected tissue. Then for posterior mitral leaflet, resection if necessary, or pericardial patch if necessary. And anterior mitral leaflet, huge, and the volume, leaflet volume is so large. After resection of infected anterior leaflet, usually required pericardial patch. And more than that, and the Gore-Tex unsupported area happens, so new Gore-Tex suture is required. And then, if necessary, angioplasty. This is my procedure. So this is the figure, like left upper side, reconstruct the mitral annulus, and then recreate the P2. And the right commissure area, and the anterior leaflet perforation, and more frequently, popular procedure is the resect the A3 commissure and the P3, and then reconstruct the using treated autologous pericardium, and also Gore-Tex. You can see this is the photograph of the patch for anterior leaflet perforation. It's very easy. And this is the, would you start how do me? This, some signal. Okay. This is a 32-year-old male suffering MMSA infection with a stroke, with the so-called, this is the emergency case, and after resection of the infected tissue of A3, including partial A2, and reconstruct the A2 and commissure area, and then move to P3. After that, the Gore-Tex Code for unsupported you can see a prolapse still here, still the pericardial anterior leaflet, and then Gore-Tex a new chordae to the homologous pericardium. And then the left ventricle was large enough to put on the so-called ring annuloplasty, prosthetic ring. This is the final result, okay? Another one. This is the 22, okay, 22 old lady, and suffering streptococcus. This is the healed patient, and the A3 was destroyed, and that's a P3, including commissure, and the healed process, there's adhesion of the leaflet and then posterior left ventricle. And then again, they're using homologous, glutaldehyde treated homologous pericardium, and then make a leaflet from A3 to P3, and then you can see a figure. There the so-called I made a slit between anterior leaflet, posterior leaflet, and then re-anastomosis. Re-anastomosis was mimic the so-called commissure, and then Gore-Tex new chordae was made for anterior pericardial leaflet. And ring annuloplasty. And this is the leaf test. It's very fine. So this is the summarized and almost 150 cases, including active and healed, and survival at 10 years and 95% and 80%. There's no significant difference. And 92% of survival at 10 years. And reoperation free, 96%. And the reinfection was very rare. And one case suffered, the organism was Candida albicans Candida. And the redo, we had 6 cases. And again, the repair 3 cases, replacement 3 cases. So the redo, freedom from redo operation is very, very acceptable. So this is the review from the Feringa, 2007, 24 studies, compared the repair and the replacement. And every result, hospital mortality, long-term mortality, early reoperation, early cerebrovascular events, late reoperation, and late recurrent endocarditis, and late cerebrovascular events, significantly better than those of replacement. So as a conclusion, the mitral valve repair is associated with the good clinical in hospital and long-term result among patients undergoing mitral valve surgery for infective endocarditis. So 2011, SDS recommend in patient native mitral valve endocarditis when technically feasible, and the mitral valve repair is recommended to treat native valve endocarditis, class 1 recommendation. So, in conclusion, the mitral valve repair for infective endocarditis provides excellent survival, freedom from reoperation, and the freedom from reinfection associated with long-term durability of repaired mitral valve in selected patients. Autologous pericardium, Gore-Tex sutures, and the prosthetic ring, if necessary, are suitable for repair in infective endocarditis. Thanks so for your attention. Thank you very much.
Thank you, Dr. Okada. Great result for 30 years. Is there any question from the floor? Yeah. Dr. Songchai.
Very nice presentation. I have one question for the pericardial patient. Do you see any patient with late calcification and come back?
Yeah, but fortunately, I didn't have such a case. Pericardium, autologous pericardium, treated autologous pericardium, becoming thicker and thicker, I guess, and smaller. So I put in a little bit larger one, redundant one. And maybe I used this technique at first for rheumatic mitral valve disease, 1991 or 1992. And at reoperation, I analyzed the so-called 19 years after autologous pericardium implantation. There was a little bit thick, but without calcification. So that's my experience of the mitral valve repair using autologous pericardium, published maybe 2013 by my colleague, Dr. Shomura.
So for the treated with glutathioneide, for how long do you how long? What?
Maybe 10 or 15 minutes. Yeah. Am I right? Yeah, but just depend on the so-called the Carpentier group published this technique in 1991. Chauveau, the pediatric surgeon, used this material, and it's very reliable. If thick or calcified, and just replace another pericardium, I guess.
Thank you, Dr. Okada.
Yeah. So next speaker coming to from Taiwan, and minimally invasive for surgery for tricuspid surgery. Am I right?
Yeah. Sorry. Yeah. Thank you, Okada-sensei. My assignment today actually is minimal invasive surgery for tricuspid valve. So I think it's a great opportunity for myself to review my practice. It's a reflection of my journey. I start with mixed, starting from mitral, aortic, and then all those tricuspid, most of them actually is concomitant surgery. I come from Taiwan, next to China, but we are different. And this is the result I have for the past 20 years. I have done more than 6,000 cases, and it's year by year accumulation. Most of them actually is coronary artery surgery, but my interest will evolve. So you can see the isolated valve surgery increase over time. And for those isolated valve, now it's more than 2,000. Aortic, isolated aortic, there's more than 500. Isolated mitral is 750, and all the others are combined procedure. All these valve procedure, you can see the trend of surgical approach has evolved significantly, especially after 2004. We have a majority sternum sparing approach. For those isolated valve surgery before 2010 and after 2011, we can see the change of the approach move from half sternotomy to now is less than 10% sternotomy. So we do have our result, a statistic of those quality measurements, like the ventilation time, the CCU stay, and also the post-op stay in the hospital. Actually, in the Asia context, it's not easy to reduce the post-op stay because patients want to stay for almost like a full recovery or independent life to being discharged home. And for this mitral valve surgery, you can see I have this statistic, but I just try to move to my next part. There will be my demonstration of my technique by video. So you can see the move from a sternum approach to non-sternum approach. And now it's less than, for the past 5 years, the sternum approach actually is now less than 4%. For those tricuspid valve surgery, I have to admit that most of them actually are concomitant surgery. So this will be very important slide for this topic. You can see rarely we have isolated tricuspid valve replacement. And sometimes we do have concomitant tricuspid valve replacement because of the significance of TR or the significance of annular dilatation. Patient has suffered from significant TR for a long time, resulting the hepatosplenomegaly and the intractable edema. So we need to fix the TR by tricuspid valve replacement. For those patients with isolated tricuspid valve repair, this also limited. It's only like 10 of them. And associated tricuspid valve repair is now it's more than 400. Another weak point of my practice is we do use a suture annuloplasty because of most of them are concomitant surgery. So the main issue I address would be mitral at most, and then aortic in the second. So that's why we tend to use the simplified technique by using suture annuloplasty. So only in few of them we have processes like ring or bend. For those tricuspid valve surgery, we also have a sternum sparing approach predominantly, and especially for the past few years. We realize, I believe most of us agree, suture annuloplasty may be inferior in the long run, especially for event-free survival, reoperation, or recurrence of TR. However, it depends on the patient, on the surgeon's idea of addressing patient's major problem, like mitral. So I also put this slide as a reflection of my practice. It's part of my weakness. And then I just try to show you my some video of our approach. I use video assist minimal invasive surgery, and the journey actually starting from direct vision to video assisted. Now we move to totally endoscopic. a lot of follower actually, most of cardiac surgeons are quite interested in this, but some of them may fail in a journey. So it's better to start with stepwise progression, using the larger incision and get the incision smaller. And I will promote everyone to use endoscope. It's quite helpful for illumination, visualization, even for broadcasting to your your team crew, and also recording for further discussion and especially for the conference. So my mixed journey actually starting from first sternotomy, larger thoracotomy, smaller and smaller, and use endoscope. So this is the routine setting of my practice right now. Actually, now I don't use the left hand instrument, left hand port. So usually it's only like a walking port, scope, and that is a left atrial. Excuse me, may I have the pointer? Yeah, and also the left atrial lift system. So this is the practice we have right now. And then, so I move to the first video. Actually, we have mitral valve surgery first, and then we move to tricuspid valve. So we can just open, you can see we have IVC snare, we have a bicava cannula. This is the SVG snare. So we have done left atrial approach for main purpose of the surgery, that is mitral valve repair or mitral valve replacement. And then we have the exposure of the tricuspid valve. You can see this, the opening of pericardium. So with the assist of the left atrial lift system and also some stage suture, we could have a certain exposure of the tricuspid valve. For the time reason, probably I have to move to the other one. I just try to show you the exposure. And this is the result we have. And for concomitant mitral plus tricuspid valve. And you can see with the first round, we do suture angioplasty for these two commissure. The commissure for anterior and posterior. The suture for the commissure ATL and PTL. And also there's the De type suture running from posterior to septal leaflet. So we could have the result same as external approach. Again, you can see we have done the mitral, we have IVC snare, we have SVG snare. We can visualize that cannula inside. We have a beta exposure of this one. You can see by using the stage suture, we attach the right atrium to the inner surface of right atrium to pericardium. So by using this exposure, we can have a very good visualization of the whole circumference of the tricuspid valve. And then the same technique we use for mitral. So we could have a running suture as the De. So this is the cannula. Some of the stage suture we need to help the exposure to visualize the whole right atrium. You can see we also have the closure line of the interatrial septum right here. So in this case, we do mitral or ASD through ASD. So we have an inner closure line right here. So after the De suture, we can use the tourniquet to adjust the length. So by using different tension, we can realize the condition of the tricuspid valve and the repeat test to get a good result. And then tie these stitches. So this is the result. You can see this is the redo procedure. So it tends to be a little bit larger than our minimal invasive surgery series because we need to deal with the adhesion not only in the pleural surface but also the pericardium. But we still could have a very good exposure like this. I'm sorry, there's a stagnation of video, but I suppose it's. You can see the exposure. This is the. I tend to use because this is a bicava. This bicava cannula is too long for Asian patient. So that's why I tend to have a big curve. Try to bring the side hole close to IVC and the hepatic vein to have a beta drainage. So there's a side hole over SVC and a side hole near right here. So we could have a very good exposure for surgeon to deal the tricuspid valve. Again, this is same approach. You can see the cannula rubber around like a ring to help exposure, and then there's a rupture core, and then we put a band on. So this exposure helps surgeon to deal with. If you have this kind of exposure, you may have a very good opportunity to teach your young generation. And then this is my way to deal with the aorta. So this is for cardiac pressure delivery. This is a pigtail catheter with the loop at the tip, so you don't need to worry about the injury to aortic leaf that. And then we have a detachable clamp, so we could save another puncture lesion. And you can see this IE after previous mitral valve repair, perforation, and also retracted PML. So that's why we have a mitral valve replacement for the lady. And then after we replace the mitral through the interatrial septum, we move to the tricuspid valve. This patient, we have a tricuspid ring. Oh no, I'm sorry, band. So this is the tricuspid exposure. Again, the cannula is looped around in the upper surface. And then we have a dependent suction to assist the exposure of the tricuspid valve. And the patient, we have band. So this is the result. This is the previous surgery and the same incision. And this is only the small trick to prevent the pole bleeding. So we could remove all those stitches afterwards. This for those patients with dense adhesion, sometimes it's not easy to have a closed clamp. So that's why we will have like a beating heart mitral valve surgery or beating valve mitral valve replacement. This is accelerated film, so you can see it's beating quite fast. But for the time's sake, I probably have to move to the other one. You can see the exposure like this because of the thickening and the retracted deep depth and rupture core. So that's why I replaced the valve. So I just try to present my talk to you. That is, open technique could be adopted by minimal invasive approach. It's only the same idea with different approach. I think the platform is very important for surgeon to realize the different approaches by using peripheral cannulation, myocardial protection, cross clamp, and then had good exposure for surgeon to apply the routine technique we learn from sternotomy approach. Try to make your technique simple and reproducible. And thank you very much.
Thank you, Mr. Chen. Kaminchu. Is there any comment and question? Yeah.
Yep. That was great. I'm sorry
Thank
I missed
you.
the beginning.
Yeah.
Just a question. Your tricuspid, you saw it so beautifully, and you bicuspidized or did a de Vega. Why didn't you put a ring in? I mean, you got the skill set or a band. I just don't understand.
Yeah.
It was
Thank
set
you.
there, you could see it so nicely, and you did the de Vega type repair, which I think is inferior. Why didn't you just put a band in?
Yeah, thank you, Trevor. So I have to admit my weakness because this is my series. So you can see right here. Yeah, indeed, most of the associated procedure, because rarely we have a isolated valve. For my more than 2,000 isolated valve series, so you can see the isolated tricuspid actually is only like a limited number. But for this associate repair, most of them are suture, really. So I admit that is my weakness. Probably because I try to limit the cross-clamp time because we already addressed the main issue of the major one, that is mitral, predominantly, as some of them are aortic. So that's why.
I think that's all very valid. It's just, you can see it so nicely in your
Yeah.
skill set, I thought. The other thing is, and I know that a lot of these were redos, the one really helpful thing is root suction when you do the tricuspid work.
Yeah.
You'd be surprised how that really helps you see the valve a lot better. And just lastly, exposure-wise, you know, the retractor with the arm that Ugo Vanderman uses, that works really well in the tricuspid as well.
Yeah,
So-
I totally agree with you. Thank you. Thank you for your reminding.
Any other question and comments? Dr. Chu, you know, the totally 540 cases and the valve replacement consists of 72 patients. Am I right?
Yeah, I think so. Yeah.
And so-called 13% of the patient, the tricuspid valve was replaced.
Yeah.
Let us know the reason why the mitral, rheumatic or severe functional mitral tricuspid regurg, or let us know the reason why you replaced the tricuspid. In Japan, totally, maybe replacement rate, maybe 2 or 3% of total mitral valve intervention, not so large.
Yeah, I think it's also a very important point from my review, my reflection on my journey. That is, that's because I have a very low ratio to repress the tricuspid valve. I don't like to have a more than mild tricuspid regurgitation after the operation, because we realized the recurrent TR might be significant impact to the quality of life after the surgery. So I think this also remind me to follow like Trevor's remind, that is try to have a ring or band and try not to repress that at that much. Yeah. Thank you.
But you know, for left side, mitral valve, considering left ventricular function, is a mitral valve repair is far more better than replacement.
Sure.
And so for right-sided, valve replacement is almost equal the right ventricular function compared to valve repair.
Yeah.
Nobody knows. We have to follow, analyze right ventricular function after good repair and valve replacement. Valve replacement is very easy to quit, stop valve regurgitation. How about the right ventricular function? Anyway, the late result, you know, after valve replacement is not so good compared to valve repair.
Sure.
So that's a real world data. So we have to follow what happened after valve replacement anyway.
Yeah.
Is there any, Professor Shibata?
Good morning, and thank you very much.
Thank you.
Beautiful video. You do the debris barrel repair or replacement, the mitral and the tricuspid in your video. You use a transceptor approach, and you prefer that, or you usually use a right side approach of the left atrium and close it?
Usually I use the left atrial approach. For those patients, probably due to dense adhesion or big atrium. So because a big atrium facilitated me to have an interatrial incision, or the patient have a previous ASD. So that's why the video right there actually is ASD patient and also the redo operation with the big atrium. But majority of my concomitant surgery, I do mitral by left atrial incision to.
And close it, and then go
Yes,
to the right
yes,
side. Okay,
yes.
thank you very much.
Thank you.
Any other question and comment? Okay, thank you very much, Professor Kamichu. And this next speaker is Samachai, and the use of Pericardium for mitral valve repair. Yeah.
Thank you very much, Mr. Chairman. It's my great pleasure to be here. My topic is the use of autologous pericardium for mitral valve repair. I have no disclosure. Autologous pericardium has been used for complex mitral valve repair for a long time. It can be used for infective endocarditis, rheumatic mitral valve, or ischemic mitral regurgitation. For infective endocarditis, it may be used for closing the defect in the leaflet or reconstruct the leaflet after debridement of the leaflet, infected leaflet. For rheumatic valve, it can be used for enlarging or augmentation the small retracted leaflet. And for ischemic MR, it also can be used for augment the leaflet to increase the coaptation surface area. The advantage of the autologous pericardium is it available to use, no cost, low rate of infection. But the problem is the technical problem, and the main problem of the autologous pericardium may be the long-term durability. This paper is all one long-term result of reconstructive surgery in rheumatic mitral valve insufficiency. This paper reports that 20% of patients with a pericardial patch remain free of operation at 10 years. And this paper from Japan is a late result of mitral valve repair with glutaraldehyde treated autologous pericardium. It showed that the rate of freedom from the operation was 82% at 10 years. And this last year paper from USA, long-term performance of fresh autologous pericardium for mitral valve leaflet repair. It showed that the rate of freedom from the operation was 84% at 10 years. And this is also the last year paper from Brussels, active infective mitral valve endocarditis. It's a repair-oriented surgery safe and durable. This paper showed that for case of active infective endocarditis, the rate of freedom from the operation was 25% at 15 years. There is still controversy about the type of autologous pericardium to be used, treated or not treated. The fresh pericardium was claimed to retract, thicken, and become fibrosis. And the treated pericardium was claimed to calcify in the long term. From my experience, I have done already 32 cases. Age is between 10 and 69 years old. There were infective endocarditis in 16 and rheumatic valve in 16. For infective endocarditis, I used a pad closure for progression of the leaflets, or used a free patch for small defect after debridement, or leaflet reconstruction after 18-sleep debridement. For rheumatic case, I used for leaflet augmentation or leaflet reconstruction for mitral valve stenosis. I show some cases. The case of infective endocarditis. This case, there is just a small hole in the leaflet, so we used only the new pericardium to close the defect. This case, there is a vegetation at the anterior leaflet. We just triangular section and reconstruct with a free patch and support with the PTFE suture and ring. this case has the vegetation at the posterior leaflet. We just triangular section and reconstruct with the pre-patch and support with PTFE. This case is the extensive destruction of the valve. So we have to remove nearly all of the anterior and posterior leaflet and reconstruct with the pericardium. This is the pre-op echo. This is the pre-discharge echo after the reconstruction. Valve is okay. And we follow the patient. This is the echo post-op 1 year. Valve is still okay. And this is 2 years post-op. For rheumatic valve, this patient is a young lady with rheumatic MR. She has a very small retracted anterior leaflet. The size of the anterior leaflet is smaller than size 26. So we have to augment anterior leaflet with the pericardium. This is a pre-discharge echo. But 6 years later, it's become calcified, thick calcified. And we have to redo the patient. This is the, you can see that's the really calcify of the leaflet, the pericardium. This patient is a young lady with a severe metal stenosis. We try, at first we try to mobilize the leaflet, but really thick, it's a really fibrosis and thick. So we use the reconstruction by resect on the thickened fibrous tissue and reconstruct with the pericardium. This is the pre-op echo. Now we move. Yes, this is good. This is a pre-discharge echo. And we follow the patient. This is a 1 year post-op. It's still open nicely and close. This is a post-op 2 years. And 4 years later. We have no hospital mortality as one late death from recurrent IE. The patient developed stroke pre-op, poor ambulation and poor hygiene. He refused the second operation. 2 patients all rheumatic valve underwent the operation. It's just a short video to show my technique for reconstruct the. This is a female, 20-year-old fever CMR. He has the on-ventilator. Vegetation at the anterior leaflet. Because she is a young female sinus, so we try to repair the valve for her. You can see the large vegetation. We begin with the annular stitch, and we use the marking stitch at the leaflet. After that, we remove the infected leaflet. We try to cut it in the triangular or rectangular. And we use the marking stitch, stitch. And we we measure the length of the pericardium to be used. And with the marking or stay suture, when we use the fresh autologous pericardium, we do the second row of suture. The first row is the continuous locking suture to prevent the bursting effect and close the gap between the suture. After that, we do the second row of running continuous suture to reinforce to reinforce the suture lines. Yes, this is the same patient. I think the marking suture or stay suture is so we can handle the pericardium easily. After that, we have to reshape the size of the pericardium. We use the sizer number 28. Cut to the and then we have to support the pericardium with the Gore-Tex suture. In this case, we use the three stitch of the PTFE suture. For the length of the cord, we use the reference point at the same as the posterior leaflet by suture. So we can tie after that. So check with water test. And then put in the link. It's a post-op echo. So in conclusion, I think autologous pericardium could be used for complex metabolic repair, but the long-term durability remains a problem. Thank you very much.
Thank you very much, Somchai. It's a very, very beautiful video, including the last case. Yeah. Let us know the patient age.
Pardon?
Last case, your video case, patient age, how old?
20.
20?
Female 20.
It's excellent,
yep.
I guess. By the way, you demonstrated the mitral stenosis for after patching anterior leaflet and the rheumatic. I don't know exactly. Anyway, you used the 26 semi-rigid ring at that case.
You mean the case with the calcified?
Case of mitral stenosis after.
I used.
You know, I used to use a much larger ring, you know, in case of such a, because of the too small, I guess. The small ring facilitate the functional mitral stenosis after repair, I guess. Am I right? Yeah. Yeah, Trevor.
Again, amazing work. There's a scaffold available, CardioCell, which is being used more and more in pediatrics. It was made in Perth by a scientist, and in pediatrics it's not calcifying, and I suspect that in due course when it becomes available It's FDA approved, and I think it's also European EC marked approved. So I think that could solve a lot of problems if that's used in the future instead of pericardium. Because in pediatric patients, it's not calcifying. And Francis Smith, who's here from South Africa, he's used in a lot of pediatric patients. So I'm not sure about the cost globally, what it'll cost you to use it, but you should have a word with him, because I think that could really change the long-term outcome for these patients quite considerably. You haven't heard of it?
Yeah.
You understand?
No, it's a decellularized scaffold.
Yeah. In my hospital, we don't have you mean
Yeah, I think cost is the problem, but it's a pity, because I think you invest so heavily in an amazing operation. If you could get that, you'd probably get an excellent long-term result.
maybe,
We don't have excellent decellularized material until now, but it's a very, very we request in some future, but the left side we don't have now a high pressure chamber. Am I right? Yeah, I know. Cardiacel doesn't have a long-term result yet. Oh, really? We hope that. But do you know currently, compared to the valve replacement results, it's very easy to compare the mitral valve repair using autologous pericardium, very cheap.
I think for the time's sake, we thank you, Dr. Songchai. So we conclude the section, and we will move on to the next section, Top Gun. Thank you for your participation.